us in the first webinar about COVID-19, what you need to know about treatment. It's our pleasure to introduce Dr. Alaa al-Mosli. She's a senior clinical pharmacist, infectious disease in Ben Sultan Military Medical City. Welcome, Dr. Alaa, to start your presentation.
Okay, assalamu alaikum everyone. Thank you, Dr. Najwa, for your introduction, and thank you for inviting me to present this presentation. So, COVID-19, what you need to know about treatment. My objectives is to overview of case definition, alpha and the diagnostics used for COVID-19, and to discuss the pathogenesis of COVID-19 as well as overview of medication use. I'm sorry for this. Okay. At the end of 2019, a cluster of patients in Wuhan, China, were diagnosed. A cluster of patients were diagnosed with pneumonia secondary to an unknown virus. It was linked to seafood market in Wuhan. It rapidly spread, resulting in epidemic throughout China, followed by increasing number of cases in other countries throughout the world. In February 2020, WHO designated the disease of the name of COVID-19, which stands for Coronavirus Disease 2019. March 2020, WHO announces COVID-19 outbreak, a pandemic. Some of, I'm sorry, I don't know what's wrong with this slide. It's just running. So some of coronaviruses infect both human and animal. The coronavirus subfamily is classified into 4 genres. The human coronavirus are 2 of these genres, alpha coronavirus and beta coronavirus. The beta coronavirus, which contains MERS-CoV, SARS-CoV-1, and SARS-CoV-2. There are medium sized enveloped positive stranded RNA viruses. Coronavirus name they took it derived from their characteristic crown-like appearance and electron microphage. So as you can see, the epidemiology of the disease. This is most of the countries have coronavirus in their community, except for a very few countries. Yemen was one of them until 2 days back. They have one case reported 2 days ago. For the dark blue, you can see that United States of America and Western Europe, including Spain and Italy, has the highest number worldwide. What about here in Saudi Arabia? Those number was stated today by the spokesman of Ministry of Health. Total number of cases in Saudi Arabia became 4,033 cases. In Riyadh, the highest was in Riyadh, 1,106 cases, and followed by Mecca, 852, Medina, 593, and then Jeddah, 581. And it become to decrease until it is 1 in region. So what are the routes of transmission? Person-to-person spread occurs mainly via respiratory droplets. When person-to-person, just 1 second, sorry. When person touches a contaminated surface and then touch their eye, nose, or mouth, SARS-CoV-2 RNA has been detected in blood and stool specimen, but according to joint WHO China report, fecal oral transmission did not appear to be significant factor in the spread of infection. Incubation period is from 2 to 14 days after inhaling the virus. Sorry, just 1 second. So what are the symptoms? Of course, dry cough. Dry cough. A fever, shortness of breath, gastrointestinal symptoms. I'm sorry, just 1 second. Sorry for this, just technical issue. Just 1 second, I will try to put the presentation again. So symptoms, hello? Yes. So symptoms from fever, fatigue, myalgia, dry cough, dyspnea, and gastrointestinal symptoms. For clinical syndrome associated with COVID-19, it ranges from mild illness to pneumonia, severe pneumonia, acute respiratory distress syndrome, sepsis, and septic shock. Risk factor for severe illness, comorbidities like cardiovascular diseases, diabetes mellitus, hypertension, chronic lung disease, cancer, chronic kidney disease, and severe obesity, as well as liver disease. So, how to diagnose or how to define COVID-19 cases? This is the WHO surveillance case definition. The clinical presentation patient will have acute respiratory illness with or without gastrointestinal. Some cases they may present with gastrointestinal symptoms like diarrhea and nausea prior to developing the respiratory tract signs and symptoms. Fever, it is most common presentation or most frequently reported, but unfortunately, elderly and people with severe comorbidities may not mount fever initially. And then other symptoms like cough, shortness of breath. And in 14 days prior to symptom onset, at least one epidemiological link. So what are the epidemiological link? Had history of travel abroad, had visited or being resident at high-risk areas like in the kingdom, like Riyadh, Mecca, Medina, Jeddah, Al Hafuf, and Al Qatif city, a close physical contact prior to symptoms with a confirmed COVID-19 case, as well as working in healthcare facility. Those are the epidemiological links. Or if any patient admitted with unexplained severe acute respiratory illness, either community-acquired pneumonia or hospital-acquired pneumonia. So how it's being diagnosed? By detection of RNA sequence by real-time reverse transcription PCR, which is nucleic acid amplification test, serological testing, and we should test for other viruses, especially respiratory viruses, to rule out active infection, active co-infection. So this is the pathogenesis. As you can see, this is the COVID-19, or sorry, the SARS virus. It has spikes all over the surface. The spikes will attach to the angiotensin converting enzyme to receptor, and then it will enter into the cell. It will start to replicate. Inside the virus, inside the host cell, which is alveolar cell in the lung. Then exocytosis of the virus to infect other host cells Viral entry and send infection trigger the host immune response, and the inflammatory cascade is initiated by antigen-presenting cells. Cytokines and interleukin-1, interleukin-6, and interleukin-8 will be secreted. For pharmacological target, you can see here the potential pharmacological targets, either to inhibit endocytosis, inhibit exocytosis, or chain termination, or inhibit protein synthesis. The other pharmacological target is immunomodulatory target, either by inhibiting interleukin-6 or a JAK inhibitor, or by giving the patient anti-SARS-CoV-2 antibodies by giving them convalescent plasma therapy. So just to notify you that those are the most medications that have been mentioned in the literature. There are many other medications, but unfortunately, there is no good solid evidence to recommend with the use or against the use of any of them, because it's a very fast growing evidence, but you can find very small studies, unfortunately, 30 patients, 200 patients, nothing have very large number, and very poor or poor structured studies, unfortunately. So those the medications we are going to talk about. We'll start with favipiravir. Favipiravir is investigational antiviral with in vitro activity against various viruses, including SARS-CoV-2. It's approved in Japan and China for treatment of influenza. Mechanism of action: inhibit viral RNA-dependent polymerase. In an open-label, prospective, randomized, multi-center study in 236 adults with COVID-19 pneumonia in China, favipiravir was associated with greater clinical recovery at day 7, at 7 days, 61 versus 52%, compared with the control group treated with another antiviral, omefinovir. As you can see, omefinovir, I will talk about it later in these slides, but just to explain to you, this medication was not approved for SARS-CoV-2 or SARS-2 treatment, but it's used as control group. So that's why it is kind of confusing, the evidence for COVID-19. Stratified by disease severity, clinical recovery rate at day 7 in patients with moderate COVID-19 pneumonia was 71% in favipiravir group versus 56% in omefinovir group or Arbidol. Clinical recovery rate with severe COVID-19 pneumonia was 6% versus there was an increased ratio of severe to critical patients in favipiravir group compared to omefinovir group. There are multiple clinical trials ongoing to evaluate the role of favipiravir in COVID-19 treatment. The reported adverse effects are increased serum uric acid, abnormal LFTs, psychiatric symptom reaction, and gastrointestinal adverse effects. Investigational antiviral agents undergoing phase 3 trials for the treatment of COVID-19 is remdesivir. I think you might heard of it. Remdesivir was initially developed for the treatment of Ebola hemorrhagic fever. It has in vitro activity against viruses, including SARS-CoV-2. The mechanism of action: remdesivir is a prodrug that is metabolized in cell and tissue to an active nucleoside triphosphate that inhibit viral RNA-dependent RNA polymerase early in the viral infectious cycle. There are multiple studies conducted to evaluate safety and antiviral activity of 5 to 10 days regimen of remdesivir in conjugation with standard of care in patients with severe to moderate COVID-19, initiated by the manufacturer. So this study was, the study I'm going to explain to you now, was published last night in New England Journal of Medicine. 61 patients received at least one dose of remdesivir in compassionate use by GHAA. 8 patients were excluded, and 53 patients, the 53 remaining patients in the analysis, 75% or 40 patients received the full 10 days course, and 19% or 10 patients received 5 to 9 days, and 3 patients received fewer than 5 days of treatment. At baseline, 30 patients or 57% were receiving mechanical ventilation and 8% receiving ECMO. During a median follow-up of 18 days, 36 patients had an improvement in oxygen support class, including 17 of 30 patients receiving mechanical ventilation who were extubated. By 20 days of follow-up, the cumulative incidence of clinical improvement as defined in the study or live discharge was 84%. A total of 25 patients or 47% were discharged. Unfortunately, 13% of the patient died. 18% among patients receiving invasive ventilation. The mortality rate was 18% among patients who are receiving invasive ventilation, 5% among those not receiving invasive ventilation. The median interval between remdesivir initiation and death was 15 days. So no viral load was collected from the patient. The duration was not the same for all the patients, and of course, no comparator, no control group. Adverse effect: increased hepatic enzymes, diarrhea, rash, renal impairment, and hypotension. Most medication that have been talked about in the media and everywhere, everyone is recommending it, chloroquine or anhydroxychloroquine. Both of them, they have been used as antimalarial for ages, and then it's used as for treating rheumatic diseases. Now it has they discovered that they had in vitro activity against many viruses, including SARS-CoV-2. It has immunomodulatory effect that theoretically could contribute to an anti-inflammatory response in patients with viral infections. Hydroxychloroquine may be more potent than chloroquine in vitro. The mechanism of action, it's not clearly known yet, but the suggestive is changes of pH, alkalinization of endosomes, and believed to prevent viral entry, transport, and post-entry events. You remember the structure. We've said that the spike protein will enter the cells, the host cell, and then they will uncoat, and then it will replicate inside the human cell. So what are the evidence for the use of chloroquine in humans? So in systematic review on the efficacy and safety of chloroquine, they include 6 articles, 1 narrative letter, 1 in vitro study, 1 editorial expert consensus paper, 2 national guidelines documents, 23 ongoing clinical trials in China. Chloroquine, they stated that chloroquine seems to be effective in limiting the replication of SARS-CoV-2 in vitro. 1 clinical trial is ongoing to evaluate the chloroquine in prevention of COVID-19 in the healthcare setting. For hydroxychloroquine, in a small pilot study conducted in China, 15 patients received hydroxychloroquine with conventional treatment and 15 patients received conventional treatment alone. Both groups received interferon, and most patients also received omefinovir or lopinavir-ritonavir. Omefinovir, it's an antiviral. We'll speak about it, but it was used at that time in China. So primary endpoint was conversion to negative PCR in pharyngeal swab on day 7. Negative PCR reported at day 7 in 13 patients, 86.7 treated with hydroxychloroquine, and 93.3 patients not treated with a drug. The data were unclear for 3 patients. Median duration from hospitalization to negative conversion and to temperature normalization were similar in both groups. What about the other combination, hydroxychloroquine combined with azithromycin? A preliminary data in an open-label, non-randomized study in France, hospitalized patients with confirmed COVID-19 was used to assess efficacy of hydroxychloroquine use. Along with or without hydroxychloroquine, untreated patient was considered or with a negative control. So we have 3 groups: hydroxychloroquine monotherapy, hydroxychloroquine plus azithromycin, and negative control. Not untreated patients. The primary endpoint was negative PCR result in nasopharyngeal sample at day 6. Data from 14 patients treated with hydroxychloroquine, 7 patients treated with hydroxychloroquine and azithromycin, and 16 were in the control group. At day 6, 57% in hydroxychloroquine and 100% in the combination group, and 12.5% in the control group had negative PCR result. At day 8, the 1 positive for patients in the combination group After it became negative, it became again positive at day 8. So as you can see, this study had very small sample size. It was not designed to compare the combination and monotherapy or negative control treatment. This combination definitely will increase the risk of QTC prolongation even after discontinuation of treatment, because the long half-life for azithromycin and hydroxychloroquine. Another study assessed the combination of hydroxychloroquine and azithromycin. 11 patients in this study, smaller number than before. 8 had significant comorbidity. At the time of treatment initiation, 11 patients had fever and received nasal oxygen therapy. Within 5 days, 1 patient died, 2 were transferred to the ICU, and 1 patient, hydroxychloroquine and azithromycin, were discontinued after 4 days because of prolongation of QT interval. Repeated nasopharyngeal swabs in 10 patients. PCR was still positive in 8 out of 10 patients, around 80% patients, at day 5 to 6 after treatment initiation. So adverse effects reported with hydroxychloroquine and chloroquine: gastrointestinal intolerance, ECG abnormalities, cardiomyopathy, neuropathy, rash, and photosensitivity. Lopinavir, ritonavir, we are kind of familiar with this drug. It's a protease inhibitor, antiretroviral, with in vitro activity against SARS-CoV and MERS-CoV. Published data currently lacking in vitro activity against SARS-CoV-2. Mechanism of action: blocks viral cell entry. So in an open-label randomized control trial from January 18 till February 3rd in Wuhan, China, they tested the lopinavir ritonavir. A hospitalized adult with severe COVID-19 compared the combination versus standard care, 99 patients in ritonavir, lopinavir, and 100 patients in the other arm. Primary endpoint was time to clinical improvement, time from randomization to improvement of 2 points on a 7-category ordinal scale, and or hospital discharge, whichever came first. And in intention to treat population, time to clinical improvement with lopinavir ritonavir compared with a standard care. Median time to clinical improvement, 16 days in both groups. The 28 days mortality rate was numerically lower in lopinavir ritonavir group, 19.2% versus 25% in intention to treat population. While modified intention to treat population, 16.7 versus 25%. So there was no significant difference in reduction of viral RNA, duration of viral RNA detectability, duration of oxygen therapy, duration of hospitalization, or time from randomization to death. Lopinavir ritonavir was stopped early in 13 patients because of adverse effects. Reported adverse effects for lopinavir ritonavir are rash, diarrhea, abdominal pain, increased serum ALT, and fatigue. So the another new medication for us is omifinavir, tenofovir. It's a broad-spectrum antiviral with in vitro activity against various viruses. Although data are limited, in vitro activity against SARS-CoV-1 and SARS-CoV-2 reported. It's approved in China and Russia for prophylaxis and treatment of influenza. Mechanism of action: it inhibits fusion between viral and cellular membrane. It's in a retrospective cohort study in 33 adults with COVID-19 in China. Primary endpoint was negative conversion in nasopharyngeal sample and progression or improvement of pneumonia. At 7 days, SARS-CoV-2 was undetectable in nasopharyngeal specimen in 75% patients treated with lopinavir ritonavir plus omifinavir versus only 35% treated patients with lopinavir ritonavir alone. So it's used in combination with lopinavir ritonavir. At 14 days, undetectable COVID-19 or PCR, SARS-CoV-2 PCR in 94% patients treated with both drugs versus 53% treated with lopinavir ritonavir alone. At 7 days, test CT were improving in 69% in patients treated with both drugs versus 29% treated with lopinavir, ritonavir alone. So another medication, tocilizumab. Tocilizumab is also used for it's monoclonal antibody approved by FDA for the treatment of cytokines release syndrome, giant cell arthritis, and rheumatoid arthritis. It's another drug we stole from rheumatology people. So significant lung injury in severe COVID-19, this is the mechanism of action. As we mentioned, a storm of cytokines. So a significant lung injury in severe COVID-19 patients secondary to a surge of inflammatory cytokines resulting in cytokine storm. So viral replication activates the innate immune system to secrete various signaling proteins such as interleukins. That results in hyperinflammation and further lung damage. So in tocilizumab theoretically used to prevent the further lung damage caused by inflammatory or immune response by the host. In preliminary data for a non-peer-reviewed single-arm Chinese trial, 21 patients with severe or critical COVID-19 infection, patient demonstrated rapid fever reduction and a reduced need for a supplemental oxygen within several days after receiving tocilizumab. Initially, it was given as single dose, 400 milligram, and then it was repeated after within 12 hours in 3 patients because of continued fever. Currently, no other supporting efficacy of tocilizumab against coronaviruses than this preliminary data. Serum ALT, AST, infusion site reaction, and infection, including herpes virus, upper respiratory tract infection, invasive fungal infection, and bacterial infection. Patients should be screened for tuberculosis before starting tocilizumab treatment because it's an immune modulatory. Another medication I'm sure that of you was received last week. I'm sure you received through WhatsApp or social media that ivermectin, the lice treatment, is effective for COVID-19. So it's an antithelmintic. It has in vitro evidence activity against SARS-CoV-2, only in vitro. It is approved by FDA for the treatment of strongyloids. It currently no published data or regarding efficacy or safety in human for the treatment of COVID-19, only in vitro. Adverse effect of ivermectin for the that is used for strongyloids and others, lymphadenitis, arthralgia, fever, tachycardia, and peripheral edema. Convalescent plasma. Today, the spokesman of Ministry of Health was asked about the efficacy of convalescent plasma. Passive immunity is delivered as anti-coronavirus body from the convalescent human plasma may offer a novel therapeutic approach for COVID-19. Mechanism of action, we are transferring a passive immunity to restore the immune system during critical illness and neutralize the virus, so to suppress the viremia. So we are just passing the passing the passive immunity or the anti-corona antibodies. Preliminary data from ongoing studies suggest improvement in clinical symptoms with no reported adverse effects. So what about the use of steroid in COVID-19 patients? WHO and CDC recommends against using corticosteroid in patients with COVID-19 pneumonia. There are other indications. This recommendation was based on other viruses. It was extrapolated from other viruses, like because it had an increased risk of mortality in patients with influenza, as well as delayed viral clearance in patients with MERS-CoV. So that's why they recommended against using it unless there is another indication, not MERS or SARS-CoV-2. So finally, this is the MOH protocol. In addition of supportive treatment, mild to moderate treatment will give hydroxychloroquine or chloroquine. For severe, combination of both hydroxychloroquine, lopinavir, ritonavir, and for critical patients, they stated a combination of the or consider remdesivir, consider vipiravir once available, or if there is a cytokines-related syndrome confirmed, consider tocilizumab to check the levels of this, interleukin-6 in the plasma. This is the very summarized slide of MOH protocol, they have defined the mild to moderate illness, severe and critical illness. Before this, maybe before 1 hour, there was no other guidelines to recommend or to do not recommend any other medication. But maybe 1 or 2 hours back, IDSA have published a guidelines for the treatment of COVID-19 treatment and diagnosis. You can find it in the IDSA website. So to conclude things up, COVID-19 pandemic has presented in an enormous global health crisis. No approved treatment yet for COVID-19. All investigational studies, hydroxychloroquine is used in many institutional protocols. There are many ongoing studies to assess the efficacy of various medication, either antivirals or immune modulator. Those are my references. And thank you. If you have any question, we'll check the chat for your questions.